Hello, everyone. Welcome back for the second session of what's proving an already exciting and interesting day. It's great to also hear, Nora and I heard the figures for the first session. Over 180 people have linked in despite the webinar COVID fatigue that everybody's feeling. So that's great news. And Nora and I will be chairing the next session. And that's case-based, phenotypes on the fringes, and we have four great speakers for you. The first speaker is Professor or Dr. Juan Pablo Kaski, Associate Professor in Pediatric Inherited Cardiology. I gave you a quick early promotion there, Juan, who is based at Great Ormond Street Hospital, and many of you will know already from his previous work in the AICC. Thank you, Juan.
Thank you. Thank you very much, Elijah, for the introduction and the promotion. Thank you also to the organizers for giving me the opportunity to talk to you about pediatric phenotypes, the things that you shouldn't miss. So this, as Elijah says, is part of a session on phenotypes on the fringes. And this is the sort of phenotype that some of my colleagues have when I sort of talk to them about pediatric inherited diseases. These are all extremely rare conditions, or so they say. And I think this is quite timely because on last Sunday was World Rare Disease Day. And it's really an opportunity to remind ourselves that although individually many of these diseases are very rare, as a group of conditions, actually they affect a large number of people and are therefore extremely important. And this is a case-based session, and so what I thought I would do is something slightly different and give you some examples, real-life examples from our clinics, just to highlight the breadth of pediatric phenotypes that we see. So this is the first example. This probably doesn't project very well on your screens, but this is a pedigree, and the patient that we are seeing is this boy here, diagnosed with hypertrophic cardiomyopathy at 6 years of age, also has a pigmentary retinopathy and developmental delay. This is his ECG, which shows ventricular pre-excitation, and an echocardiogram showing severe concentric left ventricular hypertrophy. And if we look at the pedigree, there are a number of individuals here who are dying at a very young age, so sudden death at the age of 6, death due to heart failure at the age of 14 in a male, females who are affected but at an older age, and when they do die, they die of dilated cardiomyopathy phenotypes. We also see a more distant nephew of this patient who was diagnosed at 3 months of age. Over the course of the following months, it's clear that he has a skeletal myopathy with delayed gross motor milestones and concentric severe left ventricular hypertrophy on his echocardiogram. So in this particular family, there are a number of clinical red flags that lead to the diagnosis of Danon disease, so very early onset in males, a different sort of phenotype, but females also affected, combination of ventricular pre-excitation and ventricular hypertrophy, a number of extracardiac features, and importantly, the X-linked inheritance pattern on the pedigree. So this is an example of Danon disease. Here's another example. This is a 4-month-old who presents with a murmur and failure to thrive, the only child of consanguineous parents. This is the ECG showing extreme biventricular hypertrophy, extremely abnormal repolarization, and a relatively short PR interval, though no pre-excitation on this occasion. And these are just some selected clips from his echocardiogram. So extreme left and right ventricular hypertrophy with a concentric distribution, very little in the way of a ventricular cavity. And again, these are clinical red flags that lead to the only possible diagnosis in this case, really, which is that of Pompe disease. So parental consanguinity, so we're dealing with a recessive disease, ECG and echo features of extreme biventricular hypertrophy, and a number of other extracardiac features. So these are sort of really rare diseases that perhaps we only really see in this sort of presentation in the pediatric population. But does it matter that we make these diagnoses? Well, we know that presentation in infancy, and particularly presentation of hypertrophic cardiomyopathy associated with inborn errors of metabolism, has a much worse prognosis than other causes of pediatric cardiomyopathy. So in terms of counseling, it's important to identify these phenotypes, but also increasingly there are specific treatments available for some of these conditions. So for many years, we've known that enzyme replacement therapy can result in improvement in the left ventricular hypertrophy in Pompe disease. And more recently, there are now clinical trials in humans using AAV-guided gene therapy for Danon disease. So actually making these diagnoses matters because it can potentially result in disease-specific, disease-modifying treatments. And sometimes the treatments aren't as fancy as gene therapy. So this is an example of a 7-year-old girl born of consanguineous parents with an out-of-hospital VF arrest, a clinical diagnosis of short QT syndrome, but on genetic testing has an autosomal recessive form of primary carnitine deficiency. And in this particular case, treatment with carnitine improves the ECG phenotype. Some of the rare phenotypes that we see in the pediatric population can also help to identify novel disease genes, but also to identify new mechanisms for disease for conditions that perhaps are a bit more common in the adult population. So here's an example of a new disease gene. This is a boy whose brother died suddenly at the age of 18 months from a presumed myocarditis. This is our patient's ECG, which shows some subtle repolarization abnormalities, but nothing too dramatic. But on echocardiography, there's a waxing and waning pattern of left ventricular dilatation and impaired systolic function in the context of respiratory viral illnesses. And this is an example of a biallelic PPA2 variant. This is a rare mitochondrial disease where the phenotype often develops in response to respiratory or to viral infections, or in older teenagers in response to alcohol consumption. Here's another example of a patient who presents with syncope in infancy with grossly abnormal repolarization and QT prolongation, underwent implantation of an ICD and has had multiple recurrent therapies for ventricular fibrillation. And this is a patient with a calmodulin variant. And these groups of calmodulin, variants of calmodulinopathies are increasingly recognized as causes of severe early onset forms of long QT type phenotypes, but also in some cases CPVT phenotypes. Here's another family. This is a girl with a family history of sudden cardiac death in an older sister who had been on the waiting list for cardiac transplantation. This is the resting ECG, which is very abnormal with abnormal repolarization, low voltages throughout, and intraventricular conduction delay. Has evidence of broad complex tachycardia and significantly impaired left ventricular and right ventricular systolic function. Her brother, who is a little younger at the age of 5 years, also has a very abnormal ECG with frequent ventricular ectopy and, in fact, runs of ventricular tachycardia, and a very similar echocardiographic pattern of left ventricular involvement. So this is a Carvajal syndrome-like phenotype with compound heterozygous desmoplakin variants, but really highlighting an unusual and rare presentation of arrhythmogenic cardiomyopathy in the pediatric population. And here's another example of a rare disease. Our patient is this 11-year-old boy who presented with an out-of-hospital cardiac arrest whilst swimming. This was his initial presenting ECG with QT prolongation, very abnormal repolarization, although subsequent ECGs have been much more normal. And in this particular patient, we've identified a CACNA1C variant as the cause of his disease. And looking through the literature, there are a number of other reported families with this particular variant, including this one from New Zealand, where a number of patients present often at a young age, but sometimes much later, often with symptoms, but without particularly prolonged QT intervals in many cases. And this is an example where this rare presentation in childhood can actually give us a clue as to how the phenotype may evolve. At the time of this boy's presentation, we were not aware, but his father and his paternal aunt had been under follow-up on treatment for premature atrial fibrillation. In fact, his aunt had had a cardiac arrest thought to be related to sotalol induced QT prolongation. Predictive testing in this particular family identified all of this boy's sisters as carrying the variant, and his older sister, who had a history of syncope, underwent loop recorder implantation, has had multiple episodes of pauses and evidence of sinus node disease. And so it may well be that these rare pediatric presentations can give us a clue as to how these phenotypes evolve over time. But those are all really rare pediatric phenotypes. But actually, probably what we see most frequently in the pediatric population is our presentations of phenotypes that are much more common in the ICC world. Some of these are severe and some actually very subtle. So this is an example of a very severe presentation, an 8-year-old with a beta-myosin heavy chain mutation, severe asymmetric septal hypertrophy, ventricular arrhythmia, and clearly at high risk of sudden cardiac death. And so he underwent implantation of an ICD. But in fact, what's becoming apparent, and in fact, this is a variant in a region of the gene that is well recognized to be associated with a particularly poor prognosis and with an early phenotypic presentation. But what's becoming increasingly recognized is that these severe early onset presentations of hypertrophic cardiomyopathy that we often see in childhood are in some cases associated with sudden cardiac death, but in many cases associated with a lifelong burden of disease morbidity that is primarily related to heart failure and atrial fibrillation. These are very elegant data from the SHARE registry published a couple of years ago demonstrating that. Here's another example of rare presentations of more common diseases in the pediatric population, an 8-year-old with nocturnal seizures, extreme QT prolongation, T-wave alternans, and a sodium channel mutation causing long QT type 3. This is a VAL411 variant that is very well recognized as being a high-risk variant. Here's a 9-year-old with a history of exertional syncope, with a presentation with atrial fibrillation, which is extremely rare in the pediatric population. Evidence also of sinus node disease on the resting ECG, some suspicious J-point changes in the anterior leads in the high parasternal position, more evidence of conduction disease, but also broad complex tachycardias. And this is how loss of function sodium channel variants often present in the pediatric population. So often a very high risk phenotype. And we know this, these are data from a multi-center international collaboration demonstrating that sodium channel disease presenting in childhood, particularly in pediatric probands, has a particularly poor prognosis and often has a phenotype that is overlapping between conduction disease, Brugada, and long QT syndrome. Perhaps more often than not, though, what we see are more subtle phenotypes. So this is a 4-year-old with a family history of long QT syndrome. The ECG doesn't show significant QT prolongation, but there's very abnormal T-wave morphology with T-wave notching, and this is a family with long QT type 2. Here's another long QT2 patient, 7-year-old proband presenting with dizziness after exercise, a fairly unremarkable resting ECG, but in the recovery phase of exercise, very clear QT prolongation with abnormal T-wave morphology. Again, this is a KCNH2 variant in this family, and this allowed cascade screening to the parents and other relatives in the family. We see similar things in heart muscle disease. And this is, I think, an example of the sort of thing we were talking about in the first session, where if you don't look, you won't find. This is a 14-year-old with a family history of dilated cardiomyopathy and ventricular tachycardia in the father, also history of sudden cardiac death in other more distant relatives. Fairly unremarkable resting ECG, but mild left ventricular dilatation, mildly impaired systolic function, and on sequential cardiac MRIs, a very slow progression of the disease phenotype. This is an example of a pathogenic truncating titin variant. So these phenotypes are there early on, but it's just that we don't systematically look for them in many cases. And here's another example, a 13-year-old, family history of hypertrophic cardiomyopathy with a pathogenic troponin variant, normal resting ECG, normal cardiac imaging, but has non-sustained VT on Holter monitoring. So this is part of the phenotypic expression of sarcomeric or heart muscle disease in the pediatric population. And what we also see is evidence of disease progression during childhood and during the teenage years. And I just put this slide in almost as a last-minute addition just to highlight that we do now have evidence of phenotypic disease expression, certainly for hypertrophic cardiomyopathy, below the age of 10 or below the age of 12, which are what the current guidelines recommend. And in many cases, and over a third of cases, the diagnosis in these patients actually results in a change in management. So there is a reason for doing clinical and genetic testing in these families. And evidence also to show that if we think that screening is worthwhile carrying out in this population, then actually there shouldn't really be a lower age limit for this, because there is no difference in terms of the penetrance of sarcomeric disease in children compared to adults, certainly with hypertrophic cardiomyopathy. So thinking about pediatric phenotypes, actually we're talking about a very broad range of disease expression, from preclinical all the way to severe phenotype progression. Some of these phenotypes are rare, some are subtle, some are very, very severe. And I think what's really important is that actually, in order to be able to assess this, we need a combination of old-fashioned clinical skills, clinical acumen, clinical red flags, but also state-of-the-art technologies, advanced imaging, next-generation sequencing techniques, whole genome sequencing for some of these cases. And importantly, what these pediatric phenotypes allow is opportunities for intervention, and particularly disease-modifying intervention. And in the last couple of years, there has been a proliferation of new approaches to treatment, so ranging from gene therapy for heart muscle disease, or for ion channel disease, also to small molecules that target the underlying disease pathogenesis. And so I think there are really exciting times ahead, particularly in the field of pediatric ICCs, and hopefully over the next few years we'll see a slightly changing face of some of these fringe or so-called fringe phenotypes. So thank you very much for listening.
Thank you, Juan. That was excellent. I particularly like that you said that we still needed some clinical skills. We're going to move on just in the interest of time, and we'll take the questions that have come in from your talk at the end and the discussion.